is a special one. It's in recognition of National Aboriginal Peoples Day, uh, and I'm going to start with the land acknowledgement. So I was reflecting on the land acknowledgement and reflecting on our speaker, and we don't mention the urban Indigenous often. And I think there's a reminder that there's a large urban Indigenous population that sometimes gets lost in the shuffle. So I was happy to see we had someone who would be familiar with that speaking today. I'm not sure if you'll be speaking a bit to that, but I think it is something that deserves our attention. So Ottawa is built on the unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Their culture and presence have nurtured and continue to nurture the land. CHEO also honors all First Nations, Inuit, and Métis people and their valuable past, present, and future contributions to this land. So again, today we have Dr. Ryan Giroux presenting. He's a pediatrician at St. Michael's Hospital and the Inner City Health Associates in Toronto, and an assistant professor in the Department of Pediatrics at U of T. He works primarily with the urban Indigenous children and families, along with refugee and newcomers across Toronto and Scarborough. He is Métis from the Métis Nation of Alberta, as well as mixed settler heritage, and grew up on Treaty 6 and 8 territory in his hometown of Athabasca, Alberta. He is an Indigenous educator at the Royal College of Physicians and Surgeons of Canada, the Temerity Faculty of Medicine's PGME Indigenous Health Lead, and co-chair of the CPS's First Nation, Inuit, and Métis Health Committee, and a board member of the Indigenous Physicians Association of Canada. So thank you again, Ryan, for speaking to us today, and look forward to your talk on Indigenous child health from theory to action.
Thanks very much, Pranesh. It's great to be here, and thanks for the invite. It's not too early, which I'm very happy about, but I also did realize today that I am sitting in the world's squeakiest chair. So if you hear, I'm not running over a cat or something like that. It's just the chair. But hopefully you'll be encapsulated by my talk, and so you won't even notice it. Or if there's some sort of magical thing that prevents you from hearing it, I would really appreciate that. So. Like I said, thank you very much. You have my intro. I work. I'm new to practice, so I'm just entering in my fourth year of practice here. But I've learned quite a bit over my training and into practice. And I wanted to focus today on my slides. Will focus today on what we can do to move towards action for allyship for Indigenous children as child health providers. There's going to be some time for questions at the end, and I'm happy to speak a lot more about my particular um, clinical interests are around urban Indigenous child health because that's what I work in primarily. So feel free to ask any questions at that point about anything. I feel like it would be great if this was a bit of a fireside chat, but we don't have any fire. I'm indoors, and I don't think the fire department would appreciate it all that much. Um, as I said, I work primarily with urban Indigenous children. So I have 2 full days a week of clinic in various places throughout Toronto and Scarborough. I work a lot with children who are part of the child protection system, so in foster care, kinship care, whatever it is. But I also see just community members if they need me. The way that I work is I don't require a physician referral, which is a huge barrier for many of our Indigenous families to even be able to get to see a pediatrician, which means that people can access me pretty easily, and it means that I probably see well in Toronto. I think I'm pretty much the one of the most. I see the most Indigenous kids out of probably anybody in the city. And it's a huge privilege to be able to work with the community here. So people from Métis people, but also First Nations and Inuk people as well. So today, what I wanted to focus on is a few different things. If you got these, this is what your objectives are. Talking a little bit about cultural safety. I don't want to go through what cultural safety is, because I think that's pretty easily available. But I wanted you to have a bit more in terms of best practices for cultural safety, particularly within your clinical interactions, and then figuring out what you may be able to do to take action in solidarity with Indigenous communities as it relates to Indigenous child health. And in particular, I could talk about a lot of different things, but what I will be focusing on primarily is Jordan's Principle and by extension, the Inuit Child First Initiative to discuss kind of where we are with that, because it's quite a topical piece as child health providers about where we are. So I'm going to give you some examples throughout all of this, but certainly I hope you can apply it to your own practice. And as I was in my introduction, I grew up on Treaty 6 and Treaty 8 territory. I'm from Athabasca, Alberta, which is about a couple hours north of Edmonton. And then I lived in Edmonton, followed by now Toronto, so Treaty 13 territory. My family ties are near Fort Chipewyan, Alberta. That's where my grandma was born, which is very, very, very far north, almost into the Northwest Territories. And now I have uh, family and chosen family throughout these great lands. So I wanted to start off with something that a reflection that I've gotten in these 4 years of being a staff, and even kind of before then, is what I hear a lot. And I want you to reflect on if maybe you've thought this. It's not a bad or a good thing. A lot of people come to me and they say, I've learned a lot about the history of Indigenous children in Canada or Indigenous peoples in Canada, and I think my practice or allyship, I could change it somehow, but I'm not sure how to actually do this. And I want to make sure I do it right. So then people kind of stay stagnant a little bit because they want to do it right and they're not sure how to do it. So I want you to reflect and think about is if that's you, like, are you like, okay, I really want to make sure that I'm doing this right. So take a moment. And then I'm going to challenge you a little bit because this is the nirvana fallacy, which is I want to do it right. So the nirvana fallacy is kind of there's a few different terms for it, but it's a kind of a philosophy term and kind of discusses like I have to wait until something is completely perfect in order for me to act on it. And this idea that like if you just wait or you do as much training or you do this, that, or the other thing, that you're going to actually be able to do it completely correct. And I want to tell you that you're not. Not because I don't want you to feel like you can't prepare yourself enough, or whatever it might be, but I don't want you to get stuck in this idea that you can't do anything because you don't want to make a mistake. Because in doing nothing, it's probably worse. And we all have to make mistakes and learn from that. We're physicians in a practice, right? We're all practicing. Or we're residents in residency. We're all figuring out how to do things correct, and we're constant learners. And that kind of dovetails really well into this idea of where we kind of get with cultural safety. Because I wanted to start off with cultural humility, and that's really, in my opinion, um, what the nirvana fallacy kind of leads us into. So cultural humility, this is from the federal government, is a process of self-reflection to understand personal and systemic biases and privilege. How I see it is you knowledge yourself to become a lifelong learner when it comes to understanding another's experience. You won't ever know someone's experience completely. You know your own, and you're an expert in that, but you're not going to understand someone else's experience. So you may say or do things that lead to responses from them that could be positive or negative. You will have to make mistakes, and you will have to make up for that as part of your learning process. And that's about that relationship that you build with that person, to be able to kind of, if you make a mistake, use and leverage that relationship that you have with them or the way that they see you in order to say, okay, I made a mistake and I want to make it better. So we all make mistakes, me included as an Indigenous person working in my own communities. Like I still make mistakes and I have to course correct. And it can be, that's part of this idea of being a lifelong learner. So, um, where we get, and this is kind of the overall view of what of where cultural safety comes from, is there's I think a few different things. So that in the top in blue here is I think where we kind of came from. So that a bit of a progression. So first is cultural awareness, and I did my undergraduate degree in anthropology. So this is something I was probably starting here when I was, a tiny like 18-year-old. And cultural awareness really is that acknowledgement of difference. Like there are differences between individuals and between cultures. Then things kind of shifted a little bit to cultural competence. So that's this idea that you have skills or behaviors that you can develop to provide care to diverse populations. And it's really based upon this idea of self-awareness. So like I've worked in this community, I know this community, I know what people want, if they want eye contact, if they want this, that, or the other thing. And that can be helpful, but you are not going to become competent in one, something that isn't your own, and two, you're not going to become competent in everybody, right? We live in a very diverse country. So even beyond Indigenous people, refugees and newcomers, people from other cultures, and even within cultures, things are quite different. So you're not ever going to become competent, and we can't reduce an entire experience down to competence. So I moved on to this cultural sensitivity, which is recognizing the need to respect cultural differences. So not just that they exist, but like we need to respect them. And then we kind of made it into cultural safety. And cultural safety is a idea that a person gets to decide, a person or community gets to decide whether or not they think an interaction is safe. It understands the socio-political and historical context of that person or community and requires us as practitioners to be reflective in how we've either upheld or dismantled things that might lead to their that person's experience. And it's really rooted in these three separate entities. So first we have anti-racism, which talks about power differentials between minority and dominant groups. Cultural humility, as I talked about in the last slide, is also part of that. And the third is trauma and violence informed care, which really helps us to understand what someone's response might be based on historical intergenerational trauma, personal experiences, things like that. So if you take anti-racism, cultural humility, and trauma-informed care, those are kind of the tenets that help us to understand why cultural safety is a natural progression of all those blue pieces. So I hope that makes sense. It's probably, again, I was this title is for the talk is from theory to practice. So this is the theory part. We'll get to practice. One way that we may be able to help start the conversation is how do we recognize signs of cultural unsafety? And Jessica Ball describes kind of four different ways that you may that she thinks that cultural unsafety you may be a red flag for that, right? So first would be a low utilization of available services. Second might be non-compliance, which we put in quotes, or non-adherence with treatment plans that you've provided. Third, she thinks about hesitancy in interacting with healthcare practitioners, whether that be yourself, members of the interprofessional team, or even those in kind of the social educational sphere. And last is kind of the denial of suggested problems or issues. So no, that's not a problem. I don't think that it's there. And these are kind of rooted in various different things. So I am trying to make this as interactive as possible. So please in the chat, can you suggest what are some other flags of cultural unsafety, which may be part of these four, or maybe something completely new? And I'll take a look at the chat. The thing is, I know some of you at CHEO, so if I find your name, thanks, Rada. You're one of the people I know at CHEO. A no-show, yeah, I will say that that is one that I see frequently. Not so that might kind of fall under that low utilization of available services. Let's get a couple more.
Are we looking for, sorry, this is Blaine, signs of reactions to cultural unsafety? Hello.
Anybody else?
Ryan, there was a question here. I'm not sure if you heard it.
Oh, no, I didn't.
You want to repeat the question? I think the question is, are you looking for signs of cultural unsafety, which,
Yep.
things from behavior or other signs?
Yeah. So what are some flags that you maybe someone is experiencing cultural unsafety? And Nicole, thanks so much. So silence when asking questions, right? So you might get a nod or a head shake, which can be just a normal response, but also can be a sign of cultural unsafety. Totally. Maybe one more. Uh, Delayed or late presentations, with worse health outcomes. Thanks, Nicole. I totally agree with that. Non-participant in research studies, totally. So thinking beyond just the clinical environment, not asking questions about their care plans. So I think we've all kind of, prescribed something, and some people want to know the side effects. Yep. Not answering or reuniting phone calls. Definitely, I've had that experience yesterday in my clinic where I tried and tried. Avoid answering probing questions and assuming they already have an answer, definitely. I think everybody here can probably recognize based on these answers that there are times where you kind of have maybe a bit of a gut feeling or you're just like, this seems a little bit off. And that's kind of a sign that maybe we need to think a little bit more about our interaction, that self-reflection piece that's part of cultural safety. So excellent. Thank you very much. So I'm happy to announce that you folks are going to be previewing a new Canadian Pediatric Society statement that's come out from our First Nations Inuit Métis Health Committee that really talks specifically about cultural safety in practice. So this will be available. It's currently in print, so I don't know exactly when it's going to actually be existing or printing. But I'm pretty excited to be able to share a preview with you. And I do want to just give thanks to Emily Boulia at U Laval and Sarah Citron, who's in the Yukon, who assisted with, they presented this at the CPS conference and they let me use some of their slides, which is very kind of them. This goes through some of the pieces that you'll see within this paper. So you get the first preview and consider yourselves extra lucky. Um, so I like frameworks. I think frameworks can be very helpful in understanding um, how to approach certain problems. And I've given a few frameworks in various different teaching. I think I even gave one, a different one a couple months ago. But I wanted to give this specific framework because it really talks about Indigenous child health, and I think it's going to be helpful. So we have two different frameworks. First is the Learn, Self-Reflect, and Act. And if any of you have seen the CPS Indigenous Health Resident Curriculum, or perhaps you wrote it like Rada, you would probably recognize that this existed in there. And that's that Learn, Self-Reflect, and Act is a simple framework to guide our practices. And it helps us to understand and remember systemic influences, reflect on our own positions, and take action about the things that we're seeing. But something that I think is important for us to recognize, we don't always have all of the pieces of information. And that's why we help to create the Triple H, which is something to add to your kind of social history that supports kind of a culturally safe social history. And those Triple H's are home, heritage, and healthy living. It's meant to, we've all heard of, well, I hope we've all heard of heads, threads, shades that many people already use in various different parts of social histories. And it's meant to kind of be an addition to that. So adding something else when you have an Indigenous family or patient in front of you of the things to consider. And it encourages us to explore a child's home environment, their cultural identity and connections, and their access to basics of healthy living through a lens of curiosity, and not an assumption. And we can actually apply both of these together. So the learn, self-reflect, and act, when we think about the learn piece is, I hope that many of us agree that I know that racism, colonialism, and systems shape health and care provision. This is kind of a tenet of social determinants of health. How do they do this for the patient in front of me? Is the question we're asking ourselves. For that self-reflect, part of it is I make a different relationship with each family and patient in my care, but how does my own culture or my own experiences shape the care that I give them? And last is that act piece. So I've learned and reflected on my positionality. How can I use this insight to improve how I care for the patient in front of me or for patients like them, or if you want to take it to a systemic level, their community. When we take that learn, self-reflect, and act piece and we apply it to the Triple H approach, that's kind of where I think the magic is really happening. So I'll give you an example, and this isn't, there's way more than this in the paper, so please stay tuned to when that paper comes out. But when we talk about the patient's home environment, we talk about where their community is or what their community is, their housing, connectivity in terms of phone and internet, and health services that might be available in their locale. So if we apply that if we apply the learn, self-reflect, and act to this part of the Triple H, what that might look like is, our learning is that 44% of Canada Indigenous people live in large urban centers, but also that means 56% don't. So that self-reflection piece is if I know 56% of people don't live in an urban center, do I assume that any Indigenous child lives up north? And I'm sure that you've all heard when people say they're from up north, right? Do they live up north and doesn't have any easy access to healthcare, right? Perhaps that is true, but perhaps they do have access to things that are really going to be helpful, or perhaps they have a really excellent nursing station or a physician that goes up there that really cares about them. And then the act piece would be, let's locate this family's address on a map and factor in their location to their treatment plan, which I think, we sometimes think about, but I can tell you that I have many patients who even live in the city of Toronto, who their treatment plan doesn't really factor in the fact that maybe they're an hour and a half away from a downtown children's hospital, and they wouldn't actually be able to make it. So is there something that we can do that's a bit closer to home, for example? So this can be applied beyond Indigenous families, but I think we really want this to be applied to our communities. So second is heritage, and heritage includes the language and family structure of that patient, and also what community they're from, right? How they identify. So that learn piece in the learn, self-reflect, and act, many communities practice family structures based on the entire community being responsible for child rearing and attachment, not kind of two parents or one parent being the main people for that child's development. So that self-reflect piece is, do I assume that children that are accompanied by family members other than their mother or father have absent parents, right? So if an aunt is accompanying them, if a grandparent is accompanying them, and they're, let's say, down in Ottawa, do we think that that is a reflection on that parent, right? And so are we making assumptions based on that, like, oh, they're not there, or they're in care, or whatever it might be? So what acting might look like is exploring with the accompanying caregiver how to involve the family or extended family communication, whether it's phone and video call. If we think about back to home, if we know what their internet connectivity might be or their phone availability, that factors into this too. And really, how do we involve that family or extended family, especially if they're not physically present? And that would give us some more information about who is all taking care of this child and who may be involved with their care and development. The last is healthy living, and that includes activities and food. So what learning might look like here is if we think about hunting, fishing, and berry picking, they are important cultural activities to many of our communities, and that provides traditional food to communities and families. When we self-reflect on this is, do I consider that the food served in the hospital may not be what children are used to eating at home, and may not even be available in the city, which can contribute to diet habits observed in hospitals, poor eating, and pieces like that. And so what acting might look like is advocating for families to be able to send country food, having storage options for this food for prolonged hospital stays that may improve that child's feeling of being back home when they can't be there, and help improve their appetite, pieces like that. So these are just three examples. There's, like I said, a lot more, and I wanted to try to apply it to some clinical cases next. So I feel like I'm going to be poking at everybody, and I know that you all are very good at using the chat feature. So get your best typey fingers out, and we're going to go through a clinical case. Before I do that, was there any questions about the Triple H approach and the learn, self-reflect, and act that I can clarify before we move on? Give 10 seconds. Hearing. Oh. Should heritage include historical context to the healthcare system? I would say that that you can include that certainly. Uh, You might, I mean, it doesn't really matter where you put it. If you put it under home and community, but heritage is kind of the experiences that they might have. It could definitely help you understand historical contexts to the healthcare system. So, for example, if someone's I don't know, grandmother or mother had a bad experience or was placed in a TB hospital or sanatoria, for example, like that certainly could help you understand them a bit better. It's a great point. Like I said, this is not everything. This is just an example. So there's more in the paper. Great question. Okay, let's keep on keeping on. So here's a clinical case. Um, and we have two of these. So you have 3-year-old Algonquin boy recently admitted to the ward for an MRSA superinfection of severe eczema. Um, You're following up 1 month post-discharge. The following note, please also check on expressive speech delay. And the treatment plan that you can see in the discharge summary is prescribed topical steroid cream, moisturizers, and asked to enroll with a local speech and language pathologist. Um, I think I've seen this before in my clinic. Perhaps it is something that you will see or won't see, depending on if you're a specialist, subspecialist, whatever it might be. But just think about this. In the chat, what other information could you or do you need to provide the best and safest care possible? We won't go through everything, but what's some things that would be really helpful here for you to know? Maybe even thinking about that, the new approach that I discussed. So, Rhoda, what's the home environment? How far away do they live? How close is the closest pharmacy? Great questions. For example, MRSA, who is involved in care, who's responsible for giving medications, is the dosing conducive to a usual day for the child. They have access to clean water, bathing, provided contact info for the SLP, are expected to source themselves. Thank you, Mary Elena. Totally agree with that. For the speech delay, was this based on observation versus asking? What language was assessed? These are really excellent pieces. If anyone else has any last ones, we can throw those into the chat. So a lot of the things that folks brought up were certainly a part of this. Other families have active infections, access to clean water, housing, crowding, things like that. And I do want to bring up, so I'm not sure who wrote it, Project somebody. But I don't trust that many folks have done the work yet. I feel there's not enough focus on historical harms colonialism had done. I feel it's focusing on what's wrong with Indigenous individuals' relation to the system, not the system itself. Certainly do understand that, and I agree that that we need to change this in terms of our idea that there's something wrong with Indigenous people, with my communities. Um, and that it is a system that is it's a system that has led to poor health outcomes. So that's a social determinant of health understanding. So I 100% agree with you. I do think that part of the work is learning these sorts of things, which is why part of this learn, self-reflect, and act exists, right? That learn piece. And at the end of this presentation, I do have some resources that are really those basic pieces. So 100% agree with you here. I do also want to think though that like part of it is that nirvana fallacy. Like we are going to be seeing Indigenous people in our clinics and in our hospital. So we have to act on it because if we decide not to, then we're putting our communities at a disservice. So it's a balance of those different things. But I appreciate you saying that. I'm sorry I don't know your name, but Oh, it's Blaine. Sorry. Thanks, Blaine. I was like, I don't know, but I 100% agree with you. And part of that is also holding our colleagues to account um, when we see that they're doing something or they're not kind of understanding the full historical context. So thanks for bringing that up. I wanted to make sure we didn't gloss over that. So here, I'm going back to the clinical case, lots of different great examples. We apply the learn, self-reflect, and act to this. You know, our diagnosis and treatment, have we considered barriers to treatment access? So, for example, where's the nearest pharmacy? Do they actually have that, right? Location matters. Where do we know that this patient actually lives? Let's find their address on a map and actually see what's near them. Do they have access to water? Is clean water available, or are they not able to use that, which can be very important when we're trying to manage skin conditions? Following up feasibility, like you got booked in a month, are there local care options, or do they have to come all the way down to see you? Did we actually explore that? And then those communication preferences, you know, asking what works best for the family. Perhaps they would have preferred a virtual visit, and that would have been totally fine, right? So some of these various things that we think about, we can then apply to the framework. So our learn piece is, you know, around 60, I think said 56%, but 56 to 60% of First Nations people live off reserve. There are water shortages in some communities, and bringing it back to Blaine's point, is that this is not a fault of Indigenous communities who, for hundreds of years, had access to clean water. But it is now a piece where pieces like climate change, industry have polluted those sources that we would have been using, and now we rely on kind of other systems of clean water, and the federal government or whomever it might be aren't able to get clean water to communities when they need it. If we think about the speech delay piece, is languages are differently built. In anthropology, we talk about how language is culture and culture is language. So perhaps in in this boy's language, you know, it's more important to listen when you're younger as opposed to talk, and then that might lead to a bit of a difference in may lead to a bit of a difference in our understanding of what we might call speech delay. That self-reflect piece, do I assume a child's living area? Oh, they're at CHEO, so they're probably somewhere in the Greater Ottawa Valley, right? I think you guys are pretty good at this because you see a lot of folks who are not from the Greater Ottawa area. Do I assume access to safe water for bathing, or do I actually have to ask someone, right? And do I assume access to speech and language pathology is equitable in all regions, right? Perhaps it isn't. If they're from far away, there are many places where there is no access to speech and language services. So how does that actually change what I might recommend for this family? Do I need to find different resources, et cetera? And the ACT piece is, as I said, locating your address on a map, adapting your counseling. So if we're talking about bathing or using different creams, then we might have to change that. And then using the appropriate services, contacting health centers that may be providing care to this child, using Jordan's Principle or Inuit Child First initiative to help with some of the pieces that may exist, which are systemic causes of changes, systemic causes of health inequities. Perfect. I have a second case, but I'm going to go a little bit faster. And if we have some time at the end, maybe we can go through the second case because I think I'm talking a lot. Let's move on to a relationship repair. So the clinical case essentially was a 12-month-old child who had bronchiolitis, who was brought down from from Kick in on Baffin Island. The aunt was the adult accompanying her, and the idea was that she was present at the bedside at some points and not present at other points. And there was some concern about the follow-up plan, given that the bio parents weren't there and that she wasn't there all the time. So during that hospital stay, someone from your team confronts the aunt and asks them, where she goes for long periods of time when she's not at the bedside. So quite honestly, like that I would make me pretty angry if someone asked me that, but she gets angry and threatens to take the child out of the hospital against medical advice. And she feels that the team member assumed she was out drinking when in fact she was shopping, as the prices in Ottawa are much cheaper than Kick. And that was the reason why she was away, because she was bringing things up for her family. Um, so part of this, and I mentioned it like way back, is that we don't have the Nirvana. We don't have Nirvana. We will make mistakes. People will make mistakes that perhaps were not us, but we are still responsible for mending that relationship. So how would you be able to start to repair this relationship with the aunt? Let's say you are you're the person who's talking to her next in whatever role that might be. What's some ideas on how to repair the relationship? Anybody? I'm going to tell you one thing. Apologize and acknowledge mistakes, then ask questions about their situation home. Acknowledge your own assumptions, acknowledge the history, and it's reasonable for the aunt to make her assumption. Bring a social cultural navigator with you. Totally. So, what happened in this situation is that people make assumptions. We all make assumptions about things, but those assumptions can be based in things like racism, right? So, thinking that we understand that, oh, when someone is away, um, from the bedside, that they're doing something that we have an idea what it could be, and those racist assumptions on what this aunt was doing is based in the fact of what we have been told, whether it be through media, whether it be through our own experiences, whether it be through education systems, of what, in this case, Inuk people are like or what they're doing, right? I want you to think about if this was a high-powered lawyer who was the parent of this child, do you think that they would say the same thing? Right? Oh, she's away for lots of periods of time. What are you actually doing? No, like I actually don't think that that's the case. And I think that we need to come up with the fact, like Blaine was talking about, is that we need to kind of challenge these assumptions that there's something wrong with us, but there's actually something wrong with how we perceive people. And that's why in that cultural safety piece, like the tenets of cultural safety include trauma-informed care, cultural humility, and that anti-racism piece. Because there wasn't in this relationship, there wasn't something wrong. And even if let's say this aunt was doing something that you deem is not appropriate, can we think about the reasons why that exists, right? And how racism, white supremacy, etc., has led into that action from that individual. Um, so Blaine, I'm hoping that this kind of also is important. Like if you're seeing this as well, and I want to make sure that I'm honoring your comment about the fact that it's not just something wrong with Indigenous people. So I want to say appreciate your comment again. So that was part of what I wanted to talk about. And the other thing I wanted to bring up is what allyship looks like, because we can talk a little bit about individual relationships, and that's what we've kind of been focusing on as your individual, care provider, patient relationship, family relationship, things like that. But we also do need allyship beyond that. I want to talk a little bit about another framework. Everyone get excited for allyship, and hopefully get you to understand and situate yourself in allyship. So the former Indigenous Physicians Association of Canada president, Dr. Mandy Buss, who's in Winnipeg, what she has said is allyship is relationship with accountability, and we need to be accountable to the people that we are advocating for. one way that I understand this, and this is just a way of kind of helping yourself situate yourself, is there's kind of, I think, four different maybe areas or four different four different kind of steps to of allyship, and you can fall in any of these, and it depends on which community you're talking about, right? You can be maybe more in on the left side, so more towards apathy with some communities if you're not aware of things. You can maybe be closer to advocacy if you've been working in that area for a while. And I want you to just think about for Indigenous families or for Indigenous children, kind of where you might fall in your advocacy journey. So the first is apathy. So when one really doesn't perceive a need for change, and that's upholding the status quo. We've talked about that. So I don't interact with Indigenous patients or individuals regularly. I know lots of people that have told me this. They're like, I don't see any. Have you actually asked? Do you actually know? I will be the first to admit, if you looked at me, I'm very pale. I don't think you would know unless I told you, right? So perhaps it is something that you do interact with Indigenous patients, but you're just not aware. Or this idea that I can provide good clinical care to anyone regardless of their background. Maybe you think that you can, and that's fine. But the thing is providing best clinical and safest clinical care, you actually do need to know who they are, right? Um, if people have questions about Indigenous health, I'd redirect them to the appropriate person instead of trying to engage. So that's someone else's problem to deal with. Just go talk to Dr. Giroux about it. Thanks. I appreciate the referral, but also you can engage and help in whatever way you can. I will say there's only 6 practicing Indigenous pediatricians in Canada, and so there's a lot of work to go around. Last is I'm worried about how those around me in my department or workplace would react to me changing my practice. So you're feeling a bit stagnant. So that's the apathy phase. Next is awareness. When someone knows that there's a need for a change in practice, but they're not sure about what or how to do about this. So that's kind of some incremental, maybe sporadic improvement. So where you might be in this is I've taken a course or engaged with media, books or TV to learn more about Indigenous history in Canada, and I feel really guilty about it. I'm glad that you feel guilty. We do have to do something with those feelings, right? Because if you keep those feelings to yourself, it's making it more about you and less about the people that's affected. I'm not sure how to change my practice because I don't want to offend anyone and want to do it right. Or I worry I should be if I should be the one changing, or if I should support the work of Indigenous clinicians that do the work because it's their community. Great. I love working in the community. It's my favorite. But I cannot see everybody and you will still see people, right? So thanks for supporting us, but we need you to move along with us and not just stand and watch us walk forward. Third is application. So when one actively implements changes in their practice from the knowledge they've been given from others. So I've taken steps to incorporate tenets of cultural safety in my day-to-day clinical practice, and I recognize that systems around me are inherently racist, but I don't know how to start changing systems. It feels hard to go beyond myself and my individual relationships. I think this is a lot of where many folks are at. Things have changed a little bit, but there are certainly folks who maybe haven't made it to this step, and that's okay. I want you to try. But moving beyond your individual relationships is the last piece, and that really where you get into advocacy. So when one actively implements and refines their practice from ongoing gaining of knowledge, actively reflects and evaluates their position, and harnesses their power to lift others up. So that might look like I regularly speak up when I see anti-Indigenous racism, even if it jeopardizes my relationship with that person or others. And my reaction to when my advocacy is critiqued or questioned by those in community is one of thanks and reflection, and I try to incorporate their feedback. So that last piece, Blaine, when you brought up your point earlier, we're both in community, we have different experiences, but I'm not getting defensive about it because I'm like, that is a really excellent point, and we are all advocating for the same thing, and we're all learning from each other. So when I think about that kind of critique of the things that I'm teaching, that's what I'm trying to bring in here is this advocacy piece. And so I hope that folks can do that instead of saying, maybe you'll feel a little embarrassed, but harness that embarrassment to kind of say, maybe I need to think a little bit differently about this issue. And the allyship piece here, I wanted to just bring up this teaching from Dr. Danielle Bain-Smith, who really spearheaded this, is this idea that we have to work together to support a path of eradicating anti-Indigenous racism. There's certain things that fall into the cedar basket on the left. So cedar basket is kind of Indigenous work. So that's work for Indigenous physicians or Indigenous people, and that's focusing a lot on our health and wellness. The copper pot on the right-hand side is the work of settlers, settler work. So many folks on this call, we guide what we think needs to be done. So Indigenous people guide what we think is important, but that um, implementing cultural safety, um, uh, being anti-white supremacist and anti-racist, that's work that needs to come from settlers. And so there is work to be done on both sides, but the focus should be different. Because we need to focus on our wellness, and we need you to focus on the pieces that try to take away tenets of our wellness. So I hope that gives you a sense that like we actually need you to participate in this work. We recently just passed the 10-year anniversary of the Truth and Reconciliation Commission calls to action. Many of them discuss implementation of Jordan's Principle, as does the MMIWG calls for justice. You can see both of those there. So where do we actually fit in as pediatricians? Very briefly, we did a study a while back because we were hearing that Jordan's Principle had been helpful. I'm not sure what will get fully approved. Many services are denied. Many of my colleagues are unaware of Jordan's Principle. So we did a study that was actually based out of Ottawa, with Rada being the PI. We got a number of different responses. We've presented this a couple of times, and there's a fact sheet that's on the Canadian Pediatric Society website. But essentially, a few different things that we noticed is that many folks didn't actually attempt to access services. And out of the ones that had, commonly would be things like allied health specialists and services and supports in the school setting. Many people experienced barriers in accessing funding, so including difficulty with contact, time-consuming, difficulty navigation, and an unreasonable amount of information requested to be able to support an application. Many folks hadn't had any cases that were processed within the 48-hour standard. And about a third had reported at least one denial, and many had had multiple denials. 28% had reported that there was a negative outcome for a patient and family due to delay in accessing Jordan's Principle. And I will say the reason I'm bringing this up in this allyship piece is because we have seen a huge shift in our ability to utilize the legal rule that is Jordan's Principle or the Inuit Child First Initiative. So from 2022, when the study was done, to 2025, what I've been hearing, I haven't been able to get anything approved for the past year. That's including me. I haven't been able to get anything approved. Families are unable to get reimbursed even when they pay out of pocket. And group funding requests have been important to get communities what they need, but we haven't been able to really understand why some get some and some don't. So I wanted to give you a little overview of what we're seeing right now, and perhaps how you may be able to advocate on behalf of Indigenous children to make sure that Jordan's Principle and Your Child First Initiative are fully realized. So the Caring Society, First Nations Caring Society, had filed some non-compliance motions that included our information as well as an affidavit, the information from our study. Canada had reported to the tribunal that essentially they hadn't really done any of the things they were supposed to. So they hadn't, their order was to communicate with requesters with undetermined urgent case to ensure no immediate harm. Wasn't done. Providing a detailed plan with targets and deadlines for dealing with the backlog wasn't done. Triaging backlog cases, not done. Providing guidelines regarding the avoidance of unnecessary delays in reimbursement, it wasn't done. And providing criteria, guidelines, and process for referring Jordan's Principle requesters to First Nations, not done. What they did do is they provided a report on the backlog, and I'll go into that very shortly. So in 2025, this year, another Canadian Human Rights Tribunal orders on Jordan's Principle non-compliance that was filed by the Caring Society. So backlogs are inconsistent with previous tribunal orders. It must be immediately addressed. Approval requests must be reimbursed and funded in a timely manner. Urgent request definition can be reviewed, but Canada's requested change in timelines was denied. Canada must report on coordination with federal programs, et cetera, et cetera. There's various different pieces where essentially we're still in this phase of like it still hasn't been figured out, and it's been so many years that Jordan's Principle has been here. To give you a sense of the size of this, so there is in progress. There is this was February 20th. There is 124,000 applications that have been opened, but have not been ruled on. And then there's another 10,000 requests that have not even been opened, which could be an urgent request, for example. So we have almost 135,000 as of February 20th of these backlogs. And so if you're wondering where is my patient in this, it's probably somewhere in that 135,000. And what we know is that Jordan's Principle is plugging holes in other federally funded programming, right? So if we're submitting something for housing, if we're submitting something for education, non-insured health benefits, and things are not going through those correct channels, then they're going through Jordan's Principle. So you can understand why the number of requests is going up and up and up and up, and the funding requirements is going up and up. And we know we're on the ground applying for things for First Nations and Inuit children, because we know that they need them. And if it's not going to go through Jordan's Principle, where does it go? The federal government hasn't actually told us that yet, because they don't actually. Jordan's Principle is just plugging these holes that really we should be beefing up education, health, housing, etc. So we sent out a response. Which was because of a bulletin from February 10th that discussed what the federal government would and wouldn't approve under Jordan's Principle and Inuit Child First Initiative. We support a child first response and the Human Rights Tribunal rulings. We recognize the impact on pediatricians as on the ground providers in our communities, and that we're the ones kind of sounding the alarm, and that we want to work together to find long-term solutions that support First Nations child health and Inuit child health. So what I would love for folks to be able to do, and stay tuned because we're hopefully making this something that will be easy to do through the Canadian Pediatric Society, is contacting Mandy Galmasti, who's the Minister of Indigenous Services Canada as of about a month ago, your own member of parliament or the Prime Minister's office that just says what you're experiencing when you're trying to apply or to get services for your First Nations or Inuit children through their programs. Jordan's Principle is but one of many different calls to action that have not been completed. So only 13 TRC calls to action have been completed since 2015 from the Yellowhead Institute. If you ask the federal government, it's going to be a little bit different. Very briefly, because I'll have a little bit of time for questions, as I had mentioned before, I think these are 4 really great places to start. If you're wanting to learn, if you're maybe early on your journey or you're wanting to ground yourself in a few different theories as it comes to cultural safety and Indigenous history. So here's 4 that I like. So the one on the left is from Queen's University. The one in the top, that was top left. Top right is Ontario Cultural Safety Training, which is a cost, but is an 8-week program with instructors and discussion. Bottom left, if you're a Canadian Pediatric Society member, you have access to this for free. And that's a module called Providing Culturally Safe Care for Indigenous Children and Youth, and you can get that on Pedagogy. And the bottom right is a new one if you need Section 3 credits through the Royal College. This is available as a Royal College fellow, and you get your Section 3 credits. So it's an online module as well. Important in this, though, is that that's theory. We've talked about theory to action, and I hope that in recognition of National Indigenous Peoples Day, that you think about an action that you could do that has been asked for by our communities to improve our health and well-being of children, Indigenous infants, children, and youth as a child health provider. That's where I'm going to end off. Thank you very much. Marcy can ask Matin, and I'm happy to take some questions. I'll just assume everyone's clapping really loudly.
Yeah, thank you. I was reflecting during your presentation that it would have been great to have this one in person. And thanks for your kind of interaction that you were pulling from us. This would have been a great discussion on a couple of those cases in person. I also found myself trying to think of what question I wanted to ask. So I thought of a few, but one was, in terms of that framework of learning, self-reflection, et cetera, I was kind of curious about your first 4 years as an independent practicing physician in St. Mike's. And, again, my mind is with the urban Indigenous population. And, what has that been for you? As you have transitioned now, into 5 years out into practice, you're getting into middle career soon, right?
Oh God. Don't remind me. Yeah, no, it's a great question. So to give a sense about how things were, so prior to me starting my pediatric practice, there wasn't really a whole lot of. There were some people doing some work with Indigenous communities in the GTA, but not a whole lot. So I felt like I was starting out something from scratch, and I was fortunate enough to have some really excellent family physicians who had already kind of started a lot of the clinical work, and were just looking for a pediatrician to kind of do some of the things that they really wanted to make sure that they could keep that. Um, we really wanted to keep that trust, that transfer of trust. So if they're referring to a pediatrician, they want to make sure that that person is able to care for them in a way that would remain trustworthy. Because sometimes sending people to specialists, you don't exactly know what that is going to be like, right? So I would say the first year practice is always quite difficult, as you try to adjust to a new normal and try. I remember my first probably 2 months, I would like the night before I would read through all of my patients because I was nervous, and I didn't want to miss something. And I think within the first couple of months, I had a patient in front of me that I really wasn't sure what was going on, and that like sinking feeling of like, oh my God, like why did I train for this long? Um, but and I think that's a normal piece. But I think the added piece on top of that is that, I really care about the community that I work with, and I want to make sure like uh, things travel fast. So if someone has a not so great experience, like the community gets to know it pretty well. And any of you working in community probably can attest to that. And that doesn't change from, I think, from urban environments to rural remote environments. So I think some of the greatest things that I've learned is that that relationship that I built with my patients is the most key thing for them coming back, and the most key thing for us deciding something together, and the most key thing for me to have a job. Because if we don't spend that time, maybe it's a little bit of extra time. Maybe, in the clinic, I'm in the Call Auntie clinic right now. I often will get my patients, I say, do you want a coffee? Do you want a tea? I will go make it for them and bring it back. I think that brings that power differential that exists down pretty significantly. Because people, I think, are a little bit, if they meet me the first time, they're like, oh, okay. And that power differential and that, like, assumption that racism is going to happen really starts to decrease. And if you can kind of bring those power differentials down, then people are more likely to open up. People want to come back to see you. And it's just little things like that that sometimes are the biggest deal. So I don't know. I'm sure I could write a book on this, maybe a pamphlet. But those are some of the things that kind of come to mind.
Yeah, thanks, Ryan. Other questions? I think we have time for one or two.
I have one. Ryan, thank
Yay.
you so much for presenting, and it's been so amazing to watch your career from medical student to pediatric resident and now staff in practice for so many years. And I guess in that reflection, we have many Indigenous learners, medical students, and residents. Any advice on how we can better support our Indigenous learners?
Totally. I think a couple things come to mind. one is celebrating them, right? I think we are often uh, like as Blaine had kind of mentioned, like we're kind of viewed as a problem, but like we can actually be viewed as an asset, right? Like our existence is resistance. And if you know your learners, if they're comfortable sharing that with you, celebrating them and lifting them up is one thing. And two, I think that what I would have really loved in pediatrics is actually being able to meet Indigenous pediatricians. Like we still don't have that many, but we are growing numbers. I have a note on my phone about everybody that I know of. So there are many more. There are many more Indigenous residents and medical students that are interested in pediatrics that are coming through the wings. And part of what we do at the Indigenous Physicians Association of Canada is we work on that mentorship piece because I can tell someone how I've experienced things, and I think that they really see themselves be seen in those moments. So I think that mentorship piece is another piece. And the last thing I'll say is flexibility, right? We have a lot of different objectives in our training, and we have a lot of different things that we need in terms of service, et cetera. But being able to be flexible to be able to provide those Indigenous learners with an experience that actually is meaningful to them is really important. So, for example, I was supported really well by my program to be able to be part of the Canadian Pediatric Society First Nations and Métis Health Committee. If I hadn't done that, I don't know if I'd be here, right? So we had to be flexible. And thank you for bringing me on also. It's like many years later, but I think that's another piece is that flexibility to be able to provide that. And if someone needs to, if they have a ceremony that they need to attend to, we need to let them do that because that's a huge part of of our ability to take care of ourselves before we take care of other people.
Great. So thank you again. We're just out of time, but I'm sure if anyone wants to reach out to Ryan, he'd be glad to engage speaking for you, Ryan. Thank you again, and a really important topic, and hopefully we can all improve.
Awesome. Thanks,
Okay.
Ganesh. Thank you, everybody. I
Thanks.
just put my email in the chat if you'd like to send me a quick email and or meet me in person. Come to have a coffee in Toronto.
If you're here, we can organize something too, Ryan. So
Sounds
okay.
amazing.
Great.
Thank you, everyone.
Thank you again. Bye.
Can ask Marcy.